Okay, my name is Bill Anthony, and I direct the Center for Psych Rehab, and that's who is sponsoring this event. And I've asked Alan Jetty, our dean, if he would say a few words of welcome from Boston University, and also kind of set the context of how important this colloquium is in Sargent College and Boston University. Now, we tend to be informal here, and this is a very formal setting, so we'll do our best to be informal as we go along. This is probably the only time I see my staff in coats and ties and dresses and so forth. Other than that, we are not what you call a dressed-up group, but today we certainly are. The Dean of Sargent College is a part of Boston University, Sargent College of Health and Rehabilitation Sciences. Our Dean, Alan Jetty, is also, and I had to write this down, also the director of the Boston University Health and Disability Research Institute. He's a professor at Sargent College and at the School of Public Health. And he got his degree from the School of Public Health at Michigan, I believe, right? He does a number of functions around the university and around Sargent, but his research interests, and that's what I wanted to list off here because I think they're very relevant to what we're talking about: the measurement, epidemiology, and prevention of late life disability, the study of late life exercise, and the evaluation of post-acute treatment outcomes. He's published, I think, over 125 articles in journals in geriatrics and public health and rehabilitation. He was the previous director of our Research and Training Center in outcome effectiveness, close. He was also for 10 years the director of the Roybal Center in enhancing late life function that was funded by NIA. But most importantly, he's my boss, and he's been very supportive of the center and what we're trying to do. Obviously, with his research background, his interest in clinical work as well as education, fits right into what the center is all about. So I'd like to introduce Alan Jetty for some welcoming remarks.
Thank you, Bill. Well, it's a pleasure to be here. I'm sorry I can't stay for the entire day. As Bill has noted in his warm introduction of me, I wear several hats here at the university, so I have to run off and switch hats. I'm here in two capacities today. I'm here both on behalf of President Aram Chobanian, president of Boston University, who had hoped to be here this morning. Aram is extremely interested and supportive of all areas of health promotion, and I know he wanted to be here today, but he recently underwent heart surgery, and so he's still recuperating, so he couldn't be here this morning. But so I'm here both on behalf of the university and on behalf of Sargent College, as Bill has indicated. This is a wonderful event. This is a wonderful event at a wonderful time in a fantastic history of an outstanding center here at Boston University. You know, health promotion is at the core of Sargent College of Health and Rehabilitation Sciences, and we are really unique with respect to these kinds of schools and colleges across the country. We have 14 different programs at Sargent College, all of which focus in different aspects of health promotion. And we have a long history of doing that at Sargent College. It was initiated around the theme of physical training and health promotion for health professionals 125 years ago by Dudley Allen Sargent, our founder, at a time when no one in health professional training was doing that. Dudley Allen was an innovator, and it seems to me entirely appropriate that these many years later, Boston University has been the home over the past 25 years of the Center for Psychiatric Rehabilitation, another innovator. And Bill Anthony and his colleagues over the past quarter century have become preeminent around the world in developing and disseminating and absolutely delivering the principles of care for those with psychiatric illness. And so it's a wonderful coming together of so many different threads around the theme of health promotion. The Center for Psych Rehab is an integral part of Sargent College. For me, it's always been very special to be able to support the center. One of the things that I think is particularly unique about this center, in contrast to many other centers, both in this university and other universities, is that the Center for Psych Rehab has taken extremely seriously the charge to develop and implement all three areas of academic pursuit. They have a vibrant educational programs section of the center. They have an extremely vibrant and active research component of the center. And really what is quite unique in centers of this type is they have equally as active service delivery programs where they actually put into practice the kinds of programs that they're training about, they're teaching around, and they're doing research on. So that they're not only thinkers, they're doers. And to me, that's the sign of an incredibly innovative and important center, such as our Psychiatric Rehab Center here at Boston University. So I'm delighted to have the opportunity to welcome you here today for this exciting symposium on this exciting event of the 25th anniversary of the center, and I wish you every success throughout the symposium. Thank you.
I think it's probably obvious when you have a dean who's your boss and he can talk so well informed about what you've been trying to do. It is a tremendous asset to have as a dean. Well, and he also alluded tonight to what we're going to do tonight, which is a 25th anniversary celebration of the center. And of course, you folks are all invited. Many of you have RSVP'd already that you're coming. It'll be a great event. Commissioner Hogan delivering an address, and our honored guest, who happens to be here today already. I thought she'd be sleeping in, but she's made it from England already, and Judith Turner-Croson will be our honored guest this evening. So please, everybody, and I know most of you are coming, look forward to seeing you there tonight. Okay, we're talking about really this is a dream of the center, and the person whose dream it was is Dory Hutchinson. Dory's been dreaming about this for as long as the center has been dreaming about it. And Dory's also been dreaming about having Larry Cohn take the leadership role in raising funds for this whole initiative. And she's hoping both of her dreams come true. I think Larry's here somewhere. There he is, working on the dream. Okay, so we've been involved in this, and I asked Dory when we kind of started this whole idea of health promotion. It was a long, long time ago. She and Larry were teaching the first supported ed class here at the university, and they would break at lunch and go to the gym or the pool, and some of the students asked where they were going, and they told them, and some of the students wanted to go along, so they introduced the students to the Boston University pool and gym and workout rooms and so forth. And out of that came the idea that, you know, people with psychiatric disabilities really are interested in their health, and we ought to give them the opportunity for that. Since that time, I think it was 17 years ago, Dory and Gary Schreiner, who was also here, did our first research project on health and fitness for people with psychiatric disabilities. And since then, we've made some forays. Dory has published and Gary has published other articles. We've made some forays into this area, but never really did what we're trying to do now. And I might mention that also in the audience today is Judith Boardman, who we're doing a project with, a health project that is just beginning. Ken Duckworth is here as well. We've started a project at Westbridge Community Services with Ken. So we're continuing these, I guess forays is the right word, into the health promotion area. Now, however, we want to make this a large initiative of the center. And Dory said the way to begin this initiative is by inviting all the people that really know something, and let's sit and listen and converse and learn from the folks who really know about this type of initiative. That's why we started most everything at the center as listeners, and that's what we're here to do today. I might just mention before I introduce Dory on a personal note, Dory does practice what she preaches. She has competed in a number of triathlons, she said, when she was younger. Now she's a member of a group triathlon team, whatever that means. But she says she wins for her age group. Her group triathlon team wins. So this is an important thing for Dory, both personally and professionally, to have this group here and learn from them. I want to introduce Dory right now to keep the program going.
Thank you, Bill, and good morning, everyone. I'm really delighted that you are all here today at BU for this important event. It means a great deal to me and to my colleagues at the center that you're all gathered here and were willing to come and share your expertise with us. It's important because it speaks, I think, of our collective passion about the importance of functional health and health promotion for people who have serious psychiatric illnesses. Before we get started, I wanted to share a few housekeeping details with you. In order to attend to all of our well-being, I think it's important that everyone know where the restrooms are. And there, you go out this door and you turn right down the corner, and it's your first left. There's a hallway with restrooms and a water tumbler for you as well. We also are going to be serving lunch at noon so we can be well nourished for the day. And also, we have a participant today who is deaf, and we would like to ask that when questions are asked, that when you ask questions of the speakers, that the speakers repeat the questions for everyone's benefit, and that one person speaks at a time. We also are going to be using mics, and we'll be handing those out. So when you have a question, we'll hand you a mic, and that will give the speaker time and the participant time to be ready to listen. Over the last 17 years, our services at the center have responded to the health needs of the people we serve by developing and providing educational interventions to help increase health literacy, healthy lifestyle behaviors, and really to empower people to take back their health. Over the years, as we've looked to the field for our guidance in our work, we've been impressed and inspired by the research and the practice that you are all doing to help increase our understanding of the health issues that people are living and dying from, and what health promotion interventions and policies and research are effective. We've also been struck by the disparity between what we do know and how little the field and our programs are doing to address this complex issue. We saw this disparity between knowledge and action, or the lack of science migration into practice, as an excellent opportunity to gather us all together to discuss the research and practice and service implications of health promotion for persons with serious mental illness. This day holds promise as a means to strengthen our ability to serve people more effectively as they strive to recover from the significant health consequences that accompany psychiatric disability and often interfere with optimal citizenship. We've asked you to join us today not only because we want to learn from your knowledge and expertise on these urgent issues, but because we want to hear your perspectives on why these health issues even exist to the extent that they do. We want to know what you think our field should be doing in response in our research, in our services, and in our practices. We've also asked you all here today because we highly value the relationships we have with many of you, and we hope we will have with our new colleagues. We hope today will provide us with a forum to begin to connect, to collaborate, and create a vision that will improve the functional health of people with serious mental illness so they may actively participate in their lives and in their communities. We're going to begin the day today with 3 speakers who work at the national level and who will set the context on the prevalence, significance, and implications of the health disparities from a research, systems, and financial point of view. At lunchtime, we have a very special presentation using participatory action strategy known as Photo Voice by my colleague Sasha Bowers and students from our recovery center called Picturing My Health. After lunch, we've asked 5 excellent researchers who are doing critical work to push the agenda of health promotion forward to briefly present their work, their beliefs on why it remains a critical issue, and where they think we need to go in terms of our work to improve these outcomes. The day will end with Dr. Judith Cook responding to the issues that have been presented and offering her critical perspective and analysis of the research system and policy implications. And as Bill mentioned, we'd like to invite you to our 25th anniversary celebration tonight and hope you'll join us as we reminisce and look to the future. One of our main goals today was to create opportunities to dialogue with all of you and to hear from all of you. We've kept this colloquium very small so that we could create an intimate learning environment because we seek and strongly encourage your input, your thoughts, your feelings, and expertise throughout the day. So in this spirit, we sought to find someone who could facilitate and moderate the discussion. And there was really only one person that came to mind. A long-term friend and valued colleague, Dr. David Shern, has agreed to be our facilitator and moderator of our conversations. And it's my pleasure to introduce David to all of you. David is the professor and dean of the Louis Dulappart Florida Mental Health Institute at the University of South Florida. Prior to moving to Florida, he was the director of the National Center of the Study of Issues in Public Mental Health, which is an NIMH-funded services research center located in the New York Office of Mental Health. He currently serves on the advisory board of several national organizations devoted to mental health services research and development. He has served as the chair of the mental health section of the American Public Health Association and was recently elected to the governing board of the American Public Health Association, which honored him with its Mental Health Section Award in 1995. He's been the principal and co-principal investigator on several research projects funded by the National Institute of Mental Health, the Robert Wood Johnson Foundation, NAMI, and SAMHSA. And we're very delighted to have him. So join me in welcoming David. You might just orient people to how you're doing.
Well, it's wonderful to be here, to be among friends, and to see all of you again. And resonating a little bit to some of Dory's remarks, and reflecting just a little bit on the center. My assumption is later Catherine Powers is going to talk to us a little bit about this notion of transformation and sort of the promise and the dream of the President's Commission. And I think it's important to note that the Boston University Center has been systematically involved in transformation for its full 25 years, actually longer than that. I'll never forget reading some of Bill's first papers in the Psychological Bulletin, which documented what is now taken to be just common knowledge, and that's people with psychiatric illnesses can improve their functioning. It took a while to get to the concept, I think, of recovery and to get that fully embodied. But there was a time when we actually confused people with psychiatric disabilities with people who had developmental disabilities in terms of the kinds of cognitive impairments that they might be struggling with. And it was really Bill and his colleagues' pioneering work that started to lift our vision a little bit about what people with psychiatric disabilities could, in fact, accomplish. I think, as all you know, it's been a struggle. The center, in some sense, had to prevail against strong, dominant opinions about the severe limitations that people with psychiatric disabilities had, which largely, I think, grew from the fact that we had principally observed people over the long term in psychiatric hospitals and drew an absolutely, what turns out to be a very inappropriate inference with regard to their possibilities based on that hospital data. But it was Bill and the center, Bill and all his colleagues, who started to raise our vision and has continued to raise our vision throughout the years, struggling in many ways against some pretty significant inertial forces that didn't want to move and didn't want to abandon their notion with regard to people with mental illness. Recovery now is, we realize that not only a possibility, it should be an expectation, which is a major theme of the of the President's Commission. And we need to continue to sort of try to imbue that vision with life. Now, today we're going to focus on issues that we've known about, and Dory and I are talking about this in preparation. We've known about the excess mortality for people with psychiatric illnesses for decades. For decades. Brown did his studies, did he not, Dory, way back? Do you remember?
There are some papers that go back to the 30s.
Okay, and because I'm aware of papers from the 50s. So we have a 50-year knowledge gap where we knew that people with schizophrenia and other sorts of severe illnesses were dying at rates 2 to 3 times what would be expected. And I have been amazed in my own career and the career of my colleagues that we have done so very little about this. Now, in keeping with the tradition of the BU Center, I think that Dory and her colleagues have sort of reframed this issue around one that's not focused simply on the prevention of premature mortality, on extending people's lives, but trying to contextualize it in terms of a real living human being's life and the kinds of things we need to do to promote a broad sense of health and well-being for individuals, to fully enrich their life and to do what Catherine may also talk about a little bit, this notion to promote people having a full life in the community with the expectation of health. So our conversation is going to be framed around those issues today. Dory has already sort of prefaced the structural aspects of the conversation. What we really want to do is, after the speakers have an opportunity to reflect, to think about this gap between what we know and what we do, to think about concepts of transformation, perhaps using the notion of rehab, as Bill did originally, to transform our thinking about possibilities, recovery, further transforming our thinking, and now ultimately trying to embrace a broad notion of health and well-being as the general context within which we might have these conversations. What I'm going to try to do throughout the day is to identify threads in the conversation, sort of themes that are emergent. So hopefully we'll be able to tie together many of our conversations throughout the day around some of these dominant themes so that we can leave here with a kind of a collective strategy about how we ought to proceed to deal with this, what Dory and I now, there's a half-century problem that we've understood for a half-century at least, in a much more affirmative way, and start to transform the possibilities for people who have severe psychiatric illnesses and disability associated with them, to prevent that disability from occurring and to have them embrace the possibility of a full and healthful life. So my job is to try to keep all of you in tow, identify some themes that can run through the day, and hopefully at the end of the day, with Judith's help, try to sort of marshal a vision, a context, a set of concepts that we can use to carry our work forward. Dory? One more thing, Dory. The most important thing I wanted to say, in keeping, the federal government has this great sense of suspense about it. I don't know if any of you have ever had to work with the federal government. Some of us have over the years. And although they typically get their budget right on time on October 1st, right, Catherine? Sometimes it takes them almost the entire year to decide how to spend that money. On September 30th, which I believe was last Thursday, and I think, and correct me if I'm wrong, Catherine, but I think that is the last day of the federal fiscal year, Boston University learned that it had received its 5th renewal of the 6th renewal. This quantitative stuff confuses me. Of the Boston Center for Psychiatric Rehabilitation, which is a tribute to everything that I said in my prefatory remarks, and I was supposed to mention this at that time, but I would just like to acknowledge, have all of you acknowledge what a phenomenal achievement that is and the importance of the center. Congratulations to everybody.
Thank you. We're delighted for our first speaker this morning to have Dr. Ken Duckworth with us. Ken is a wonderful friend and a tremendous asset to the field of psychiatric rehabilitation. He currently is the medical director for the National Alliance for the Mentally Ill. He has been the medical director and acting commissioner of mental health in Massachusetts, and he's board certified in child, adolescent, adult, and forensic psychiatry. We are working with him in his role as an outreach psychiatrist for Westbridge Community Services in a wellness project that we're collaborating on. and he's also an assistant professor at the Harvard Medical School. He has won numerous awards from the National Alliance for the Mentally Ill and the Massachusetts Psychiatric Society Award for Clinical Excellence. He's been very active in galvanizing the state medical directors to look at the issue of health promotion, premature mortality, and the issue of coexisting comorbidities in people with serious mental illness. He is working with state medical directors to formally write a position paper on health promotion, and he has developed the NAMI educational program called Hearts and Minds, highlighting consumers who have made lifestyle changes to reduce their cardiovascular risk. So it's my pleasure to welcome Dr. Ken Duckworth.
Good morning. As a technologically impaired person, I'm asking Tara to help me. She has been quite gracious. My name is Ken Duckworth, and I'm the Recovering Commissioner of Mental Health here in Massachusetts. I'd like to talk to you a little bit about a topic that I've become quite passionate about, but it's not because I was trained to be passionate about it. It was just an experience that kept coming upon me when I was the clinical director at the Massachusetts Mental Health Center. I can do this talk without slides, but it's more fun with slides. The slides are basically jokes, and with content, tucked in there. But here we go. This being Boston, this being October, this being anticipatory for all sorts of human suffering, I thought I would start with a classic slide. 1964, when you came to my beloved community mental health center, the Massachusetts Mental Health Center, in 1964, you were given a brochure called Welcome to the Mental Health Center. What it is a 40-year ago today biopsy of what we thought at the Community Mental Health Center. Now, I was 5 years old at the time, so don't drag me into this conceptual model, but it's germane to say, how did the clinicians, how did the system understand what they were about? Take a look at this slide. Tell me what's wrong with the slide. This is called Meet Your Psychiatric Treatment Team. That's what the heading at the bottom is. Those of you who sat in back will see the disadvantage of sitting in the bleachers. There are plenty of seats in the front if any of you are interested. Let's take a look at the players. Anything you notice? Anything jump out at you? This will not appear in your dean's letter, by the way, so just sing things out. Everybody's against the patient. Everyone is playing against the patient. Thank you very much. What else do you notice about the slide? There's about a dozen things. I'm just going to pick out a few of my favorites if you don't pick them up. Germane to Dory's work and Bill's work and the brilliant place that BU's taking your rehabilitation center, there's a recreation therapist. Now, he's deep in right field, but he is on the field. And the chaplain is deep in left field, but the idea that people had a spiritual life was part of the conceptualization of the work. Who's missing? There's no family. The family is not on the field or even watching. Who's watching are basically the clinical director who is on his knees. You see him down there in the corner? That's kind of a universally transcendent thing. Having been the clinical director, I can tell you that's a very common place where you end up. But it is interesting how the work has changed and how it has not. So now I think if you were to conceptualize things, the idea of playing, having a recreation therapist, a spiritual life, and a multidisciplinary team is precisely what you'd want. I think the patient would be pitching. Now they wouldn't necessarily be called a patient. They'd be called whatever they want to be called. And they would be pitching against symptoms, disability, and I would add cognitive delays and problems, which NIMH is picking up on in a very big way with their Matrix research initiative. And I think also the patient will be pitching against early cardiovascular mortality, which I'm going to talk about. When I was at Mass Mental Health Center, I was impressed that when I was the medical director there during the 90s, I ran a lot of memorial services. And I mean a lot. I don't mean like 2 a year. I mean a lot. One day a woman came up to me and said, "You know, Dr. Kent, you've gotten terrific at running these memorial services. The way when they're Catholic, you bring in the priest. When they're Buddhist, you bring in the Buddhist person. When they're Upanishad, you find a Upanishad guy." It's true. We were terrific at running memorial services. Then it occurred to me, I'm the medical director of the Harvard Medical School's Community Mental Health Center. So I started to look into it. I may be a teacher. I may be a clinician. I may like baseball. I'm not a researcher. I was immediately humbled by the fact that my denominator at Mass Mental Health Center of 1,200 people with serious and persistent mental health didn't touch the question. So the way life works is life is very interesting. I said, you know, I've got to get my mind around this because I wasn't trained at all to think about people's health. I wasn't trained at all to think about their cardiovascular risk at all. And I mean at all. At this world-famous place that I had come because everybody told me when I was in medical school it was the best place to train. So then the phone rang, and it was Commissioner Mary Lou Sutters. She said, would you like to be the state medical director? And I said, well, now we're talking about a denominator. Now we're getting somewhere. There's 24,000 people in the Department of Mental Health system. And so I told her, if you will let me study this question, because I feel there's something very real, and I think it's different than what I was taught, and I think it's actually different than what happened when I was a resident, I will take the job. And she said yes, which was politically courageous, because the things I found, while on the front page of the Globe in a very positive way, I think one of the great PR home runs of her tenure, actually because it was proactive and it was honest. It wasn't a scandal. It wasn't something the Globe was finding out. We were saying, we're concerned about something. Now, Tara, how do I do the next slide? This is really the whole next level here. Let's try that. All right. I'm going to do these slides a little fast, but I'm going to focus on the ones that are the most important. This just says we serve a lot of patients, and they have to have serious and persistent mental illnesses. For 40 years, you know that there's been a whole standardized mortality problem, as was mentioned earlier. In Massachusetts, when this data was looked at in 1992, it turned out cardiovascular risk was not elevated. What people were dying of was suicides and accidents. It's interesting. Now, maybe that the population changed. It did. There's a gazillion factors in it, but it's just what was found. Basically, to get into the Department of Mental Health, you have to have a deep-end psychiatric disorder, and you have to have it for at least a year, and it has to be impacting your functioning. Many people in the Department of Mental Health have coexisting substance abuse problems, but you can't get into the Department of Mental Health if you fundamentally have a substance abuse problem as your primary diagnosis, if you have mental retardation as your primary diagnosis. So people basically have psychotic or severely psychiatric conditions, plus other things. Okay, I just want to take a look at this. So this is 3 years of data. We're now on 5 years of data. We're going to try to publish this in one of the major medical journals. And I should acknowledge my teammates. Elsie Freeman is a psychiatrist who understands public health at a whole nother level than I do, which is that she actually is willing to crunch numbers and think about it. I knew there was a rat in that woodpile, but I couldn't find it without her. And she and Robert Goldstein in the department helped us to do this. Just to give you the idea, so this is all ages 25 to 64. To make a long story short, even with a denominator of 24,000, what the medical examiner calls heart disease mortality, and that's one of the variables that we're living with, the gross numbers aren't that big. So the relative risk looks like it's 2 or 3 times what the population risk is. But if you break it down by age, you get a really, really big number, which is that basically if you're 25 to 34, your mortality risk from heart disease is about 6 times the Massachusetts population. And that's because nobody's supposed to die of heart disease in their 20s and 30s. 35 to 44, it's 5, and 5 times as much risk. And 45 to 54, it goes down to 2.8, but that's because the general population is catching up with the Department of Mental Health population. This has been quite a revelation for me, because if you're working with somebody who has poor insight or cognitive limitations and a tremendous amount of difficulties, there's only a couple things you're going to be able to pull off. And that's been my experience. HIV, hepatitis C, and cardiovascular health, I think, are the 3 things that many of us triage based on what we've seen from the data. Okay, so there's just a graphic depiction of that. Over time, the Massachusetts population does catch up. Okay, so you have a man drowning, asking Lassie for help. Lassie then goes to the psychoanalyst's office and get help. The question I have is, when people come to us for psychiatric care, are they getting the right kind of help that they need? What's fun about this new role that I have at Westbridge is actually we're talking to people very actively about the role of exercise, the role of diet, the role of nutrition, and how, if you want to get off of some of these medicines, like antidepressants, there is an evidence base that heavy aerobic exercise is not bad for mild depression. It's not bad for anxiety. We have the advantage of having a whole assertive community treatment team, but the data for that also shows in assertive community treatment, people get better health care because it's integrated. And I'm sure there'll be lots of talks about the fragmented care system later. Liver disease and diabetes, also a problem, but the numbers are so low it's hard to make sense of. But I did just want to highlight the fact that there are other causes. There's 4 people dying of pneumonia in the Department of Mental Health, but nobody should die of pneumonia. I mean, that is a preventable condition, so we have a whole vaccination program that we put together at the department. So I'm skipping through these slides, but here's another cultural biopsy for you. This is from a magazine, 1958. Before I had children, I had hobbies, and one of them was to peruse antique/junk stores. And I found this on the back of Collier's magazine. And basically, more doctors smoke Camels than any other cigarette. Now, I graduated from Mass Mental Health Center's residency training program, child program, and forensic program. No one ever once said the word smoking as an intervention or something for me to think about. Basically, I think this is kind of internalized stigma within the field. People don't have anything else to do. This is a way for them to occupy themselves. It wasn't really until 1994, 95 that people started to conceptualize smoking as a kind of self-medication. And so the whole idea that there are certain neuroreceptors around nicotine that people like to activate kind of is a whole other way of thinking about it. There's a woman named Eden Evans at the Freedom Trail Clinic who I try to send people to. And she runs group for people with psychotic illnesses who are trying to cut down or quit smoking. Her results show that there's no difference between the psychiatric population and the so-called general population. Interesting. People want to quit. It's really, really hard to quit. But you can do it. And Eden Evans has really shown us that. That's interesting because smoking is a big driver for cardiovascular mortality. Just a brief thing about how culture can change and how glad I am that BE is doing this work. So 1961, this is a study from JAMA. Doctors did not tell anybody they had cancer. Anybody. 95% of the time, 93% of the time. 16 years later, little consumer movement, a couple lawsuits, some other intervention. Now, it's unimaginable that you wouldn't be given information. So it's interesting. I feel like medical culture is this fascinating beast which looks completely immovable, and then it turns like a catamaran. And I think that is happening around the issue of wellness and how cognition and thinking relates to self-care. And I can see that in my travels down in Washington, but also here in Massachusetts. One of my colleagues got interested in this little project I started, and he basically looked at people who were still alive, which is a somewhat more affirming perspective, I'm sure. And he basically found that if you looked at what was in the charts, now perhaps you can consider that everything that's in the charts isn't the whole story, but at least if it was in the chart, it represents an absolute minimum for what is going on with the person. And basically what he found, hearts and lungs. Hearts, lungs, and endocrine is what he found for people with serious psychiatric illness. So basically what I was finding in the people who had died was what he was finding in the people who were living in our group residences here in Massachusetts. Now an interesting study comes up where stigma interfaces with cardiovascular care. Because you can say, well, it's a lot of lifestyle, it's alcohol, it's smoking, it's relationships, it's all these kind of many factors. And we know relationships are good for your heart. And we know it's really hard on your brain and your body to have a major psychiatric illness. It makes sense, doesn't it? I mean, it's really, really a big stress. There's a fellow named Benjamin Druss at Yale, and he did a study basically looking at people who had a psychiatric illness or who did not, at the deep end, the tertiary care end. Whenever I give a talk, I ask residents and medical students how many of them have had a family member who's had an angioplasty. I'll do it now. How many of you have had a family member who's had an angiogram or an angioplasty? How many of you know of a person who receives psychiatric services, who has received an angiogram or an angioplasty? Fewer hands, fewer. What's up with that? They have the same hearts and a higher risk. Well, basically what Benjamin Druss found is doctors don't do the same kind of intensive care for people with psychiatric illness as people who do not. So it's not all upstream lifestyle and prevention. It's also downstream stuff. That the kind of intervention that Bill Clinton gets is the kind of intervention that everybody needs and wants, but not everybody's getting. So basically, Druss said the deficits in quality of the medical care seem to explain a substantial portion of the excess mortality experienced by patients with mental disorders after a myocardial infarction. So what he's saying is within the doctors, it's the same stigma that has been internalized by the doctors and perhaps the patients that lead them to believe that they don't deserve deep end services. Do you hear what I hear? The mental hospital choir. This slide came to me in the medical, if you get into the Honor Society in medical school, they put you in this club. This was the first issue I ever got to my home. And I thought, oh, isn't this a fascinating way we're going to be dealing with difficult things in our field? And I was impressed by the fact that I never saw anything else that made fun of any category of people other than people with psychiatric illness. So this is if you get into the Honor Society in medical school. These are the jokes that they publish. Now, cartoons are a great topic. We work out all sorts of things in cartoons. But that the editor of a journal said, I'm going to put that cartoon and send it to all the medical students we have in the Honor Society, seems a little curious to me, perhaps worse than that. Let me just illustrate another problem. This is a death report I got at the Department of Mental Health, and I publish it as a 37-year-old woman. And by my count, I could be wrong, I think there's 34 ingestions of medications per day, just to give you an idea. Now, these illnesses can be really, really bad and cause a lot of trouble. But there is no evidence base when you get past a certain point. All medicines have side effects. And that's why in Massachusetts, when we had a gun to our head around the cost of medications, we developed an initiative. I made it up one day. It's amazing. These jobs are amazing. I said, why don't we focus on polypharmacy instead of taking the drugs away from the doctors and the patients? And so we did. And it's kind of interesting how that's worked out. But this is kind of what I was seeing. I would read every death report that came through the Department of Mental Health. And almost no one who was dying young was on one or two medicines. Now, that doesn't mean that those medicines cause that, right? It's correlation, it's not causation. But it's distressing because it speaks to the fact that this isn't tidy care, right? There's a lot of different doctors prescribing a lot of different things for people. This shows that within our hospitals, a lot of people were getting more than one antipsychotic at the same time. This data isn't perfect, but it's interesting to show that routinely we're using more than one antipsychotic to help people in an ongoing way. I don't think that's a good thing. I think it can be okay some of the time, but you should know that there's no scientific basis for it. This is more of a faith-based initiative, that you and the patient together are trying to figure out something that might help. And I'm not against that. I am for things that might help. But they shouldn't be cloaked in the guise of science. And this is one of the things that we need from the feds, is to organize studies of multiple interventions of medicines. Don Goff is running a multi-center study of lamotrigine for positive symptoms in psychosis. Fabulous. Great idea. It's not an antipsychotic, and it might work because it has to do with glutamate. We need studies of things like this, because what I see is people on a lot of medicines, and I'm not sure what the clinical return is for many people. Let me stop by just talking about a couple things NAMI is doing. NAMI's the greatest little group. It's the best job I've ever had. I said to them, why don't we do a little videotape of people who changed their lives around their cardiovascular risk? And they said, great. And so all the states, the state offices have one, and more can be gotten. And to make a long story short, there's a series of people who made the decision to reduce their drinking, stop smoking, lose 60 pounds, even while taking a compound that is complicated for weight control, to take a look at their diabetes, to decide not to take oral hypoglycemics, but rather to exercise, change the way they organize their days and their lives. What's cool about this videotape is the people. The people are unbelievably compelling. And if you like it another time, you know, I can get you information on how to get it, or at a future talk, I can show it to you. Because basically what it is people saying, I made the decision to do this and this and this. I made the decision to do this. Then I got support in order to get that. So let me stop by really thanking BU for doing this. BU helped a lot of the people that I worked with at Mass Mental because it gave them a social role that was acceptable. We all want to be students. Nobody wants to be a psychiatric patient. It's a club nobody wants to join. And if you can be a student at least in my experience. If you can be a student and use your strengths, if you can have a job, if you can work with your family, enjoy your family, love your family, have them love you, and basically have your illness be something you contend with, but not be the defining thing about you, then your lives are obviously greatly improved. So I feel like with BU working on this question of kind of integrating care into people's lives, you're basically looking at quality of life, which we all want for ourselves and for the people we work with. And I would add, quantity of life becomes a very important aspect of quality. So let me stop there, and thank you for having me.
Ken, that was outstanding, and I really, I think, picked up on several themes that likely will be with us through the day. One is, I think, this notion of inertia, talking about your own training, how you didn't even really think about health. And my guess is when you say health in that sense, you're really talking about the treatment of illness as opposed to the promotion of well-being. And it's an important distinction I think we'll talk about for the rest of the day, but really focus just on the issues of the psychiatric care for individuals. Something you said that was interesting, that's a little bit, for me, it's maybe a bit of a side conversation, but it's a riddle that we have to figure out how to solve, and that is when you were talking about getting a large enough sample size to feel as though you had some reasonably good estimates of excess mortality, and that incredible slides that shows how that changes across the age range. In order to sort of proof your sample, if you will, you said these are all people with severe psychiatric illnesses, and to get into this group, you have to have significant functional impairment headed over your typical definition that's used in community support program definitions. What's interesting to me is another major theme you talk about is access to care. And while I was very much a part of the sort of the movement in public mental health to try to focus in on people with severe disabilities, which we did during the CSP era, we now are faced with this incredible riddle of essentially setting up a situation where in order to get into public care, a person already has to have experienced significant disability. So it's access to care both within our systems, because we're requiring people to be disabled and to have been severely ill for a year before they can get access to our systems. And there's a riddle there. It's a riddle about assuring people who need support and services access to it, but not setting up a set of perverse incentives that require people to get ill. This is particularly clear if you look at young people and transition age youth coming out of children's systems, which are more focused on rehab and education, into adult systems, which unfortunately have become very focused on working just with people with profound disabilities. Somehow we need to continue to tease that out. And then you hit several other themes that I think will be really important: stigma and access to care in general, as it relates to training, but also Ben Druss's paper with regard to cardiovascular disease. We're going to hear more, I think, about polypharmacy later and the better management of issues. So those are some of the themes that I took out of your remarks. I think it really sets a wonderful stage for us in terms of the history and the challenge and the transformation we're looking for. And now, Dory, we'll open it up for comments or questions. Questions or comments, Dory or Cheryl?
Until the entire presentation.
Okay.
Might be better to do that.
Okay. Why don't we go ahead then?
Our next speaker we're delighted to have with us today is Catherine Powers. And Catherine is the director of the Center for Mental Health Services, Substance Abuse, and Mental Health Services Administration, known as SAMHSA and CMHS. As director, Catherine provides and leads the SAMHSA CMH staff in addressing the 21st century challenges and opportunities presented to the nation's system of quality mental health care, and she's responsible for facilitating the transformation change called for in the President's New Freedom Commission on Mental Health report, Achieving the Promise. Prior to her appointment as the CMH director, Catherine served for over 10 years as the director of the Rhode Island Department of Mental Health Retardation in Hospitals, and had previously directed the Rhode Island Office of Substance Abuse. So we're very pleased to have Catherine with us today.
There she is, miraculous. That's great, thank you. Good morning, everyone. Thank you very much for inviting me to be with you today, and I really want to commend this organization and the members of the audience for making sure that there is a perceptive insight into the essential link between mental health and physical health. And I want to extend my congratulations to Dr. Bill Anthony and to all of the members of the Center for Psychiatric Rehabilitation. They are partners, will continue to be partners, and we're honored to be here with you today. As we all know, the mind and the body are inseparable. We cannot treat one effectively without treating the other. Consequently, the Substance Abuse and Mental Health Services Administration, or SAMHSA, is proud to contribute to the Center for Psychiatric Rehabilitation. This center is an outstanding example of how the mental health community can embrace a mind-body approach to health promotion. I firmly believe that a more holistic view of human nature will drive future research and treatment of all health problems, including mental health. This concept is entering the mainstream, as seen by the recent coverage in publications for a general audience. In its last issue, Newsweek magazine collaborated with the Harvard Medical School to publish a special Health for Life report. Called The New Science of Mind and Body, the report begins with this very intriguing statement, quote, "From anger to optimism, our emotions are physiological states. The brain, as the source of those states, offers a potential gateway to other tissues and organs, the heart and blood vessels, to the gut, and even the immune system." Close quote. What an incredible, phenomenal concept, whose time, I believe, has finally come. A more appropriate title for the article would have been "The Renewed Science of Mind and Body," as was indicated by some of David and Dory's comments. The link between mental and physical health dates back at least 2 millennia, when the Roman Lucius Seneca wrote, "It is part of the cure to wish to be cured." So what happened to this appreciation of the mind-body connection? When did we apparently abandon a wide-open highway to a more holistic understanding of health? And of course, the schism is usually attributed to Descartes. A 17th century philosopher, he believed that the body was a separate being because a body part could be removed without taking away from the mind. He wrote, "I regard the body as a machine so built and put together that still, although it had no mind, it would not fail to move." Descartes' influential but misleading writings about the separation of mind and body led to a whole new philosophy of medicine. The fields of mental and physical health care soon veered off onto two separate paths. How ironic. The word health derives from the Greek word meaning whole. It is only within the past few decades that the mind-body connection has begun to regain widespread acceptance. Incredible advances in research technology now allow us to scan the brain to trace the links between brain and body changes. Former Surgeon General David Satcher said that one of the foremost contributions of contemporary research is the extent to which it has mended the destructive split between mental and physical health. Our two fields, again, are traveling toward a more holistic approach to healthcare. Our greatest common challenge? As Newsweek reported, we must now map the pathways linking mental states to medical ones and learn how to travel them at will. It will be a daunting trip, but I believe it will be an exciting one. This meeting, I believe, is part of that journey. We have gathered to discuss the specific issue of health promotion for people with psychiatric disabilities. Why is this issue particularly critical? Because the life expectancy for individuals with serious mental illnesses is about 10 years fewer than the general population. The reasons for this difference, you've heard some already this morning. Suicide, a high rate of accidents, and very poor health. The time has come for all health fields to help eliminate this disparity by taking a more holistic view of the human condition. We in the mental health community recently have been given a roadmap to help us reach this destination. This roadmap is called Achieving the Promise, Transforming Mental Health Care in America. I've made copies of this report available to you for the conference in your packets. Please take this and read it. It is the single most important document for the future of mental health care in America. Our success in implementing its recommendations will have tremendous impact on the overall future health care of our nation, as well as the overall health of persons with psychiatric disabilities. Achieving the Promise is the final report of the President's New Freedom Commission on Mental Health. 2 years ago, President Bush established this commission to examine the problems of our current mental health system and to recommend ways to eliminate them. About a year ago, the commission completed its review. In its report, the commission describes a system in fragments. Services are disconnected and often are inadequate. Instead of ready access to quality care, the system presents barriers that too often add to the burden of mental illnesses, a burden borne by individuals, by families, and our communities. I think it's important for us to understand contextually this idea of disease burden. The World Health Organization identified mental illnesses as the leading cause of disability worldwide, accounting for nearly 25% of all disability across major industrialized countries. In the United States, mental illnesses are on par with cancer and heart disease as a cause of disability. Physical illnesses frequently accompany mental illnesses, thereby compounding the disease burden. We can think of this burden in individual or family terms, and we can sympathize with their tragic loss. We can and must think also of the burden on the economic health and well-being of our communities. What do we lose when the full costs of mental illnesses are assessed? The New Freedom Commission clearly had these costs in mind when it stated that the nation had a vested interest and a tremendous stake in correcting the flaws in mental health care. The New Freedom Commission, as well as the World Health Organization and the Surgeon General, have called for a public health approach to mental illnesses. The public health model is concerned with the health of an entire population. It stresses the links between health and the physical, psychological, cultural, and social environments in which people live, work, and go to school. It ensures conditions in which people remain healthy by using health promotion and disease prevention to improve and enhance the quality of life. The public health model also differs from the medical model. It looks at the whole person rather than just focusing on the disease. This holistic approach to wellness means that we would consider an individual's psychiatric illness in context with other aspects of the individual's well-being. There are very few mental health systems, or mental health directors for that matter, who may in fact be schooled in the public health model, or even in the holistic approach to wellness. The state of mental health in the United States is a public health crisis requiring a public health solution. In any given year, 44 million Americans will have a diagnosable mental illness. 13 million will have a serious mental illness such as schizophrenia, bipolar disorder, or a major depressive disorder. More than 30,000 individuals will commit suicide. Suicide is a public health crisis of staggering proportion. Surely the critical state of our nation's mental health is reflected in other epidemics that now confront us, such as obesity and hypertension. The New Freedom Commission did not believe our nation could address our public health crisis adequately through piecemeal reform. Instead, the Commission called for a fundamental transformation to our mental health system. Now, transformation is an enormous concept, and one that I get to talk about a lot. It connotes a complete upheaval and a reorganization of what we know, of what we do, and how we are used to doing it. Ultimately, transformation is about newness, about new values, about new attitudes, and about new beliefs. It is about what we can accomplish now that we were unable to do before. The New Freedom Commission gave us a vision of what mental health care should be like in the future. This vision is based on a system that centers on the consumer, focuses on recovery, and builds resilience to face life's challenges. This is the direction we must take to achieve the promise of a transformed mental health care system. The Commission gave us 6 broad goals and 19 recommendations for our roadmap for change. These goals and recommendations are road markers by which we can steer our efforts and chart our progress. The very first goal of a transformed system, Americans will understand that mental health is essential to overall health. This administration has placed the Substance Abuse and Mental Health Services Administration, or SAMHSA, in the driver's seat. SAMHSA, through its 3 centers, and particularly through the center that I run, the Center for Mental Health Services, is responsible for making certain the Commission's goals and recommendations are put into place. We see this responsibility as a tremendous opportunity to bring about needed change. But opportunities come with obligations, some of which I'm going to pass on to you. This morning, I'm going to focus on the New Freedom Commission's overarching goal for a transformed mental health system. That goal is recovery. For some individuals, recovery is the ability to live a fulfilling and productive life despite a disability. For others, recovery implies a reduction or complete remission of symptoms. For still others, recovery simply means being able to make choices about their own lives, particularly about their own wellness. Overall, recovery refers to the process by which individuals with serious mental illnesses are able to live and work and learn and participate fully in their communities. This last phrase that David already repeated, to participate fully in the community, is the promise that the New Freedom Commission referred to in the title of its report. This phrase reflects SAMHSA's vision of a life in the community for everyone. It echoes the mission of the Center for Psychiatric Rehabilitation, which is helping people with psychiatric illnesses lead fulfilling lives. It is also the basis for the individualized plans of care that are called for in achieving the promise. Individualized plans of care are the vehicles that can transform mental health care. Consumer-driven and focused on recovery, these plans are the essence of a transformation because they take a holistic view of each individual, and we have not done a good job of individualized plans of care in our systems. Ideally, they will encompass the many facets of health and wellness, including a person's physical, social, emotional, spiritual, and intellectual needs. All of these facets help to determine and help to define a person's place in the community. Health promotion, which can be effective in promoting recovery, will be a very critical element of these plans. These plans represent a shift away from the traditional approach to health care, which tends to focus on illness instead of wellness. A focus on illness is reactive, with treatment responding only to the immediate health problem. A focus on wellness, on the other hand, proactively addresses the broader holistic dimensions of an individual's health problem. Illnesses, whether mental or physical, can well be a warning to consumers and providers alike that emotional, social, and other facets of health need attention. Promoting better physical health for individuals with psychiatric disabilities, however, presents its own set of challenges. The sad reality is that many people with serious mental illnesses often face barriers to a healthful life. These barriers include enormous social isolation, unemployment, underemployment, little or no insurance coverage, poverty, and homelessness. In addition, the very nature of many psychiatric disabilities makes it inherently harder for individuals to participate in their own health care. Untreated mental illnesses can impede their ability to care for their own health or to seek care in a timely, effective manner. Medical problems may result from negative side effects of medication being taken to manage the mental disorder, such as weight gain and obesity-related complications. In turn, chronic physical health problems can compound an individual's level of stress, anxiety, and depression. The mental health community often assigns responsibility to better integrate mental and physical health care to primary care providers. Why? Well, intuitively, this makes sense because about 70% of the care for common mental disorders is delivered in general medical settings. 70% of the care for common mental disorders is delivered in general medical settings. Primary care providers have a responsibility to respond to this situation. Primary care physicians must be trained better to diagnose, to treat, and to make appropriate referrals for individuals with mental illnesses. They must become aware of evidence-based practices and advances in mental health. When seeing a patient with a psychiatric illness, they must not lose sight of the individual's need for overall health and wellness. In short, as frontline providers who deliver the majority of mental health care, primary care physicians must adequately prepare to serve the whole person, mind and body together. On the other hand, we in the mental health arena need to do so much more. We need to take steps to become stronger partners with consumers in promoting their physical and overall wellness. System-wide, psychiatric services need to adapt to the needs of the people that we serve. Clinics should be equipped to carry out wellness assessments. Our training should include basic elements of disease detection, disease management, and disease prevention. In addition, we need to build more bridges between all of the communities that have a stake in mental health. Just last month, the World Health Organization published documents reporting that other sectors, such as childcare, education, labor, and housing, can initiate effective interventions to promote the mental health of our communities. They are stepping out, and we should pay attention and follow. Basically, we need to eliminate the distinction between the quality and kinds of services available for physical and mental health. If we did that, we would leap forward. Eliminate the distinction between the quality and kind of services available for physical and mental health. As long as mental illnesses are seen as existing separately from physical illnesses, the mind is separate from the body, mental illnesses will never receive the attention or the funding that they deserve. Ultimately, transforming mental health care into holistic health care will come down to the provider-consumer level. This is the point at which providers and consumers, in a partnership, develop individualized plans of care. These plans are an opportunity to respond to the whole person and his or her comprehensive needs to achieve wellness. But as I said earlier, these opportunities carry obligations. I urge you as researchers, providers, and consumers to take your part in transformation. These are my challenges for providers. Reorient your focus from illness to wellness. Don't focus exclusively on an individual's mental illness, because a focus on illness fails to address the full spectrum of supports and services a person needs for recovery. Remember that diseases are not static. An individual's health and mental health needs will vary throughout their recovery. Proactively address health issues. Consumers may not mention their health concerns to a mental health provider, so make it your responsibility to conduct regular health screenings. I said that we would have transformed America when the next time I go in and see my internist, she does an assessment about my mental health. We will have transformed America when that happens. Mental health problems and medication side effects can mask co-occurring physical problems. It is essential to be vigilant. Explore alternative routes to wellness. Pills and procedures are incomplete models of care. Build those activities known to support recovery into individualized plans of care. Exercise and good nutrition are essential to recovery from both mental and physical disorders, as well as to a person's overall quality of life. Better social relationships also stimulate wellness and recovery. In fact, one Yale study found that socialization was a key part of keeping a person with a serious mental illness out of the hospital. Build hope in recovery. In his book, The Anatomy of Hope, required reading for all of my staff, Dr. Jerome Groopman describes how hope can affect fundamental physiological processes aiding and promoting recovery. Hope, he writes, is an act of defiance that permits a person to live his life on his own terms. It is part of the human spirit to endure and give a miracle a chance to happen. Create trauma-informed systems of care. Trauma, whether it's experienced in childhood or as an adult, leaves a legacy of overlapping physical and psychological impact. SAMHSA recently conducted a 5-year study of women with co-occurring mental and substance abuse disorders and histories of physical and sexual abuse, which, by the way, are the expectation again, not the exception for people with serious mental illnesses in terms of having both physical and sexual abuse in their lives. Nearly half of the women in our study also reported serious physical illnesses. These illnesses were the kinds that limit daily life activities or require the use of special equipment. The key to recovery for many individuals may lie in addressing their underlying history of trauma. You can become a partner, a teacher, and a coach for consumers. Too often, consumers are not encouraged, not educated, not empowered to participate in their own care. This situation defies logic. There are serious choices to be made about care. Choices in providers and medications, choices about supports needed for a life in the community. Who better than consumers to determine which choices will help achieve their own personal goals for recovery? For those who are consumers, my greatest challenge to you is this: become the drivers of the mental health system. Advocate for consumer and family-centered care at every level. Take responsibility for your individualized plan of care. Consumer-directed care depends on your willingness to take risks, to chart your own individual journeys toward recovery. My philosophy is that everyone else in a care system is simply the honorable traveling companion of a consumer. Do not doubt your power as a consumer or your right to choose your future. Each step you take is a step toward wellness and a full life in the community. Nancy Fudge is the consumer director of Florida SDC, a recovery program based on self-directed care. She recently wrote to us about the remarks that she gave to the Institute of Medicine. In her letter, she said this: "I hope my testimony reflected on the importance of being given the opportunity to live a self-directed life and its effect on the personal process of recovery. I know there are many concerns over the capacity or competency of an individual and whether or not they are capable of directing their own care. The real issue isn't about whether a person needs assistance or not, but that they have a voice and a choice and access to services based on their individual needs at all levels of care. Every opportunity of choice is a seed that will grow into a healthy, empowered, self-directed life. It's about eliminating dependency in individuals who are capable of moving forward with their lives." These are my challenges to providers and consumers to create a more holistic approach to mental health care. I hope that with all of my being, you leave this conference inspired, ready to see yourself and others as the wonderfully complex human beings we all are. This coming Sunday is October 10th. On this day, the World Federation for Mental Health, with former First Lady Rosalind Carter as honorary chair, is sponsoring World Mental Health Day. How many people knew that was World Mental Health Day on October 10th? This year's theme is the relationship of physical and mental health, co-occurring physical and mental disorders. The Federation stresses that this effort is part of a long-term educational process to change how people think about mental health and wellness. The Federation's message is this: health is a complete state of well-being, and there is no health without mental health. I hope that you'll find a way to share that message with others. The road to transformation of mental health care will be a long and challenging one. To arrive at this destination, SAMHSA will need your help. Each of you can be an agent of change. We think the work of the Center for Psychiatric Rehabilitation is right on. Your inspiration, your participation, and your commitment at the community level can fuel our efforts, help pave the way for change, and build more bridges among all stakeholders. The future is not something that just happens. We create it by the actions that we take now, that the center will take now, that we will all take now in the present. The direction of mental health care begins with each of us today. More than the health of individuals with psychiatric illnesses is at stake, though that is supremely important. The health and well-being of our communities, of our country, those who live within those communities, and those who we love are also at stake. And I commend you for your tremendous interest and this wonderful opportunity to be with you today. Thank you very much.
Catherine, thank you. We live in very propitious times, I think. We're so lucky that finally we've come to fully appreciate the relationship between mind and body, and that mental health is in fact fundamental to health. We have the President's Commission, I think, that has so wonderfully articulated that theme. And I think we are so lucky to have Catherine Power as the head of the Center for Mental Health Services, because Catherine really gets it on all levels. And every time I hear her speak, I am re-inspired about the power of the dominant themes that are emerging. And Catherine, it's just, we're so lucky to have you in this position at this time. I say that with great sincerity. So you did think that going back 50 years was bad. I mean, Catherine took us back to Descartes and to dualism and the separation of mind and body. And that is definitely an issue that we've struggled with for a long time and will continue to struggle with, even in terms of the way we think about and characterize disease. It's clear to me, and I assume to many of you, that with things like the global burden of disease, the study that the World Bank actually initially commissioned, and our new sense about the loss of community productivity, personal productivity, and our overall well-being that results from psychiatric illnesses, that I hope that the conversation has been fundamentally reframed, and I think that's what Catherine was calling for us to certainly to move away from that dualism and to move into the mainstream. I remember one of the first times I was ever with Catherine was at a Technical Assistance Center meeting in Washington when she was commissioner in Rhode Island. And I can't remember the exact context of the conversation, but she was talking about being at a cabinet meeting with people from health and welfare and feeling somewhat marginalized in terms of their conversations, but realizing that that is where the action was occurring in terms of the mainstream focus of government and well-being of communities. That vision is in some sense coming to fruition now in trying to understand how we can better incorporate mental health within a general health well-being framework. It's captured by, I think, the notion of a life in the community. But I think, as Catherine said, this comes with great challenges for us. Think back to Ken's notion about you can't get into care until you already have a severe disability in most states. We've got a lot of work to do to try to integrate these concerns into the mainstream, to take this holistic notion of health and not lose the focus on people who are vulnerable and are suffering with disability. So for me, this is one of the themes that's kind of emerging, is we've got a vision of well-being that we're moving toward. We have a legacy of people who are disabled by their illness and by the society in which we live, and somehow we need to comport with both of those simultaneously as we move forward to a much more integrated set of concepts to guide us to well-being and health. And it's not just about the health of people with psychiatric illnesses. It's really fundamentally about all of our health. We all have a personal family stake in this. So some very powerful themes have emerged and some great challenges, I think, in the first two speakers. We've definitely moved into the mainstream. We can see that there are a lot of inertial forces coming from our training and our background, the very structure of our own systems that we need to transform and move along toward a much more encompassing notion of health and well-being for all of us, but particularly for people who have illnesses and disability related to their mental health. So, number two. Dory?
Our next speaker this morning is another close and dear friend of the Center's, Richard Searles. Richard is a Senior Vice President and Director at Comprehensive Neuroscience in White Plains, New York. He heads CNS's efforts in the areas of outcome research, clinical guidelines, reimbursement services, and behavioral pharmacy management. With over 25 years of executive experience in government and the private sector, he is focused on the organization and financing of service delivery systems for people with severe mental illness and disabilities. In another life, he served as the Commissioner of Mental Health for the state of Vermont, the Administrator of Mental Health and Mental Retardation for the city and county of Philadelphia, and he was the first non-physician Commissioner of Mental Health for the state of New York. Richard has received extensive career recognition from organizations such as the American Psychiatric Association, the National Alliance for the Mentally Ill, the National Mental Health Association, and the Greater New York Hospital Association. In 1993, he was inducted as an honorary fellow of the American Psychiatric Association, and he has been a member of the Carter Center Mental Health Task Force since 1992. Please join me in welcoming Dr. Richard Searles.
I may need some help getting set up here. So, let's see. Ah. All right. I got to step one, so. Great. Thank you. I think I may have been the first governmental client of the Boston Center. Bill tells me I was the first government client in 1979, and Bill Anthony, McKell Cohen, Barry Cohen made a trip into Vermont to work with me on trying to convince the State Rehabilitation Agency to integrate with the Office of Mental Health and to really work towards creating a recovery-oriented model. Vermont actually had been an early leader. There was a psychiatrist, George Brooks, who actually very much believed in rehabilitation. And Courtney Harding and Strauss at Yale had actually done some of the work that actually showed early on that people with severe psychiatric disorders got better in the community. It was a very early, that and some European studies actually started were the backbone of actually saying recovery is possible. And I got to participate in that, and it really had a profound effect on me. So every place I went, I suddenly tried to say, well, how can we reorganize this place so that we have a recovery orientation? And that's really going to be my theme today, is how do you organize? I'm a social psychologist by training, and I'm always trying to think about once we create a sense that change needs to occur, what do you do next? I mean, I think the message this morning is it's taken a long time for us to acknowledge the healthcare problem within the disease state that we've been managing as an independent disease state. And so I'm always looking for new platforms for change. If you can come to a vision of the way things should be, what do you do to move towards that vision? And in this day and time, it's much harder than I think it was in 1979 and the 1990s when I was in New York. It's a much more difficult environment to work in. So I want to go through a couple of initiatives that we've been taking, but think more about the platform on which the initiatives are placed. It's really the techniques we are using to try to introduce the idea that change needs to occur and to use information in a way that had not been previously used. In some ways, so many of the concepts are quite simple. The truth of the matter is we frequently found that simple concepts are not easy to implement. My main theme is around Medicaid. Medicaid is the largest single payer for persons with severe mental illness. The techniques I'm going to describe to you, we also are adapting to the commercial sector. It's been amazing to look at health plans and self-employed insurers. The cost of services in many health plans for mental health services is now down to like $2 or $3 per member per month. But the cost of pharmaceutical services in mental health is now $10, and I've seen some plans up to $16 per member per month. So we've had a transformation in the private marketplace in which fewer and fewer people are getting direct care, but they're getting far more medication, and in many cases being improperly both treated and medicated. But the focus today is Medicaid and Medicaid outpatient. None of my remarks and none of my data is really about what's happening in inpatient hospital situations, mainly because we don't have very good data there. What we have is excellent data for the Medicaid program for outpatient care, ambulatory care, where most of the people really are. Keep in mind that one of the obstacles of trying to bring reform to the payment system through Medicaid is Medicaid's an insurance company. It's no different than Blue Cross Blue Shield in terms of what its mission is. It has a benefit. It has to manage to a benefit. It pays claims. It's not a program. Medicaid also has to accept any willing provider. It's not a payer that can say, I want to have certain specialists that are going to see patients. It has to have an open door policy. As long as you meet minimum standards, you can get a Medicaid provider number in any state. And the numbers are stunning. If just in the area of people receiving a mental health benefit in the states, give you a range. State of Missouri, where we're working, 523,000 outpatient persons, of which about 200,000 receive a mental health benefit any quarter from 8,000 different doctors. Florida, where we'll be working with David Shern, 2.1 million Medicaid recipients, 28,000 physicians in any given month seeing a person with a mental illness receiving a prescription. So the numbers are stunning. Clinical data in Medicaid only comes about when somebody pays a claim. So the truth of the matter is, when we talk about information in Medicaid, you don't get that information. It's not available until a claim is actually paid. So if there's a dispute about a claim, there's no data. And probably more important, data in Medicaid is organized in many buckets. And those buckets don't pour into each other very easily. So you've got a separate bucket for laboratory claims, for inpatient claims, outpatient claims, clinic services, pharmacy services are all different claims file. And fortunately, in terms of what I'm going to show you today and some of the ways that we're trying to drive reconsideration of how to improve the safety of prescribing, and ultimately, when we come to people with severe mental illness, how we might use pharmacy data to help us predict who might most need care in the future. Now, I just said that Medicaid is paid claims files, insurance company, very conservative, very traditional. Truth of the matter is, there are a whole series of new thinking about how we can use claims file to improve health care. Being led by initially some of the large employers in the U.S. that started raising questions about, can we use our health data differently? Some of the things going on now around the country in Medicaid is that data now is being used for disease management. And I'm going to talk about an example of some work we're doing in trying to create a disease management program for persons with severe mental illness, which heavily focuses on the co-occurring healthcare problems. And it's really, once you start looking at the Medicaid data for persons with a diagnosis of schizophrenia, it's stunning the healthcare issues that emerge that we haven't been looking at. A lot of the problems with that data is many diagnoses, many physicians. The record is one patient in Missouri had last year over 300 different physicians that signed some clinical chart. So we've got issues there we have to deal with. Reducing errors, again, there's a whole literature emerging in health affairs about what can you do to use information to help physicians and prescribers understand where they may be using medications or engaging in clinical practice that put patients at risk. Service coordination, I'll come back with some examples of this. And last, risk prediction. Again, this is something else that's coming out of the healthcare area. David and I were together in New York, and we were a period of a lot of excitement around the intensive case management programs, and we were enrolling patients all over New York in the intensive case management program. And upon doing retrospective reviews, we didn't do a very good job of selecting which patients should be in intensive case management because our risk predicting model was flawed. We focused very heavily on cost, not on clinical issues. And the net result was, after we studied it, we found that cost alone would predict future use only 20% of the time. So we were enrolling a lot of people that probably would have been just as well not to be intensive case in the program, and we were leaving out people that needed to be there. So these are the kind of the themes that you're seeing now as people are thinking about how do we try to transform the Medicaid program, again realizing that these are state-based programs, how might we work with them, especially as we move into improving the integration of physical health with mental health, really focusing on what could we do to recognize that people with severe mental illnesses are people with physical illnesses that frequently that are under-recognized, under-treated, or improperly treated. A lot of problems. As I've already mentioned, many providers, many sites of services, millions of claims in many different buckets. And there's not a lot of money out there right now to pay for innovations. This is not an environment in which we have a lot of patience with walking into a Medicaid agency and saying, gee, you've been doing this all wrong and I'm here to help. So the techniques, and again, when you think about as you go through your deliberation, I think what I'm trying to offer today is techniques, not so much content. That when you think about if we're going to try to take some of the knowledge we have and start to transform some of our systems of care, we've got to realize some of the challenges that we're going to face. And one is there's a huge amount of extremely useful data in these payment systems. When you start to learn how to use them, they can produce, if organized properly, remarkably informative information to caregivers. And that's really the goal that I have, is how do you use data so that people that are responsible for caregiving can do a better job? And part of our assumption is with good information, people will want to do a better job. Second issue is you got to keep costs down. Some of the disease management programs are extraordinarily expensive. So how do you find a way that you can use existing data, find a low-cost technique for getting that data to the people that need it the most? And it really, back to Catherine's point, ultimately this comes back to the relationship between the consumer of service and the person that is working with them in their caregiving environment, whether it's a psychiatrist, a case manager, a primary care physician, a pediatrician. And less burden on Medicaid and providers from an administrative point of view. Most of the Medicaid agencies and the provider organizations cannot take a new initiative if it requires new staff, new services, new forms. Working with one state Medicaid agency that 2 years ago was managing 600,000 Medicaid recipients with 120 staff. Today they're managing 830,000 with 60 staff. So the idea that you go in and say, gee, we've got this great new thing we want you to do, there's just no tolerance. It has to be, it's going to be virtually no burden on the agency if you're going to expect them to respond positively. Or you show them a way that you can substantially improve care, improve access to care that will result in less burden and less cost. I want to talk to you about two different techniques. One of them is an appropriate use strategy, and this is the one that we're in quite a number of states. And the other is a new approach to disease management with schizophrenia and co-occurring physical illnesses. And I think some of the data that Ken was showing and some of Catherine's comments from the President's Commission, the prevalence of physical illness is far greater than people probably realized, in part because the nature of the stigma of getting the mental illness label, that people overlooks the frequency of some of the physical disease issues that it's impacting on the person's life. Again, principles using existing data sets, supportive of existing providers, educational in nature, continuous quality improvement, and improve coordination between mental health and medical care. That's the goal of everything that we're trying to do. The first one is what we call behavioral pharmacy management services. We're actually now in 16 state Medicaid authorities, and almost all these states, these are cooperative ventures between Medicaid and mental health, but we have to convince the Medicaid people first to do this. The reason we're there is, in Florida, the governor's budget was proposing to allow the state Medicaid authority to limit access to antidepressives, antipsychotics, and anticonvulsives. And they were going to allow, actually it was going to be a fail first program. A patient was going to have to absolutely fail in an outpatient setting on one of two products in order to even be considered to have access to other antipsychotic medication. We've developed this program as an alternative to fail first, and the whole goal being to allow choice and open access. But the technique is to clarify best practice. The second one I'll talk a little bit more about actually than the first is what we call medication risk management for schizophrenia. Again, it's focusing heavily on the way drugs are being used, but this time it's focusing on everything, the physical health care drugs and the psychiatric drugs, as well as the clinical history. You actually have to know, like the last year, the ICD-9. You look for both the diagnoses that are in the record, and then you try to parallel, we run them through a series of algorithms looking for errors and medical problems. And the issue here is to link both psychiatry, physical health, and community providers, and provide useful, meaningful, easy to understand, ready access to data that will help the caregivers make better decisions. So behavioral pharmacy, again, I'm going to move through this rapidly, but to give you a sense of it, we don't ask Medicaid to do anything. They simply send us pharmacy data. And we run the pharmacy data through what is now 39 different indicators looking for problem practices and redundant practices and risky practices. In this program, we're looking for physicians that appear to be struggling within their practices. This is not patients focused specifically. You're looking for the doctors that are engaging in practices that are clearly deviations from evidence-based practice and appropriate practice. Again, you're thinking about huge databases. You have to do something that's reasonable. We then let that prescriber know that, gee, you're writing prescriptions for 7 patients, for 3 antipsychotics for the last 6 months, and you should be well aware that federal guidelines, APA guidelines, that practice is considered inappropriate. You should move towards monotherapy. Again, a simple message. It gives the physician back their own data. They get a 90-day profile of their patient, and they're asked to consider making a change. There's absolutely no requirement to change. There's no recommendation around what medications to use, but it's raising an awareness that their practice is a dramatic deviation from accepted best practice guidelines, et cetera. And then we track those changes, and we track also a lot of the work we do focuses on adherence, the fact that people do, while they're in Medicaid, they stop taking their medication. The physicians, the case managers would have no way of knowing that. And so we provide rapid feedback to let them know that the person has discontinued their antipsychotic medication. Just to give you some examples, and again, like I say, we're now up to 39, but we're looking for therapeutic duplication of antipsychotic, excess dosing, the excess switching, multiple prescribers. This is a very large issue when we first go in. It is amazing the number of people that are getting an antipsychotic, getting maybe an atypical from their psychiatrist, but they're also seeing a primary care physician and getting Haldol, and neither one of them knows about the other. And physicians respond very well to this particular issue. We age band by child, adult, and children, and there are different messages by age. What's so interesting about this particular program is there's a very small percentage of physicians that really need advice, if you will. And part of that's the design of the mental health system, in that people with severe mental illness going to community mental health centers cluster around a small number of physicians. I mean, it's not uncommon for a physician, a psychiatrist in a community mental health clinic to be carrying a caseload of 600 patients. In Pennsylvania, they refer to it as a 6-minute hour, that the person is seen at best once a month for 6 minutes. Very rapid decisions, usually based upon if there's no dramatic change, you get the same thing you were getting last month. So part of what works out in this is this intervention doesn't require us to contact thousands and thousands of doctors, but just a very small percentage, usually under 3%. And we don't go away. They get a quality letter to tell them what the problem is. They actually get told that they get information about the level of deviation from best practice. They get a patient drug history, which on one page, which they very much appreciate, and they get educational briefs. And if we end up with treatment-resistant physicians, they get called by a peer. We actually, in every state, have put up a panel of well-known psychiatrists that actually will call the physician that is not responding. I was pretty skeptical. This thing is now in its 4th year, but we've been in Missouri for 2 years, about would physicians respond to letter series. And the data is far better than I had thought. There is a literature out there that suggests that mailing things to doctors doesn't work. But I think we believe if you target it correctly, you don't go away, and you ultimately follow up, you get a pretty good response. Now, I'm just going to show you this for a couple of examples here. This is prescribers providing more than 2 antipsychotic agents, and this is Missouri, and this was for the first 6 months of the program in the state of Missouri. There were 1,469 physician outliers writing more than 2 prescriptions for atypicals, and you had to have done that for at least 3 months. So it was, if you wanted, you would go away. You actually saw in the period that we had about 639 doctors moved to monotherapy. They improved their dosing, they moved to monotherapy. No, I'm sorry, the blue line, it's 44% of the doctors, 645, changed their practice, affecting 60% of the patients. But it's also interesting, and we didn't catch this early on, that every month, some physicians change, but every month we're getting significant additional people and doctors. So in the 6 months, which is the last month of this study, there were 185 new doctors and 450 new patients that came under review that had moved towards multiple therapeutic duplication. The one that we've received the most response from, and actually I think that physicians have really appreciated, is the multiple prescribers. The medical community is actually very good at, when it sees an issue, of taking action and self-correction. This was, when we started, there were 1,112 different prescribers, multiple prescribers, affecting the lives of 1,330 patients. As you can see, dramatic change. That almost taken care of itself. So the primary message around the first one is their pharmacy data is really the best source of data we have right now in many respects because it's the most current, that you can build inference models around the level of prescription, the duration of prescription, and you can start to message around things that you believe are critical in the lives of patients seeing community-based physicians, and that they do respond for the most part. The second one is a lot more complicated, and that is there was a conference recently in which a series of experts in schizophrenia said it's impossible to create a disease management program in schizophrenia. I think we don't believe that's the case, but we're certainly going to find out. We're in the process of implementing the first disease management program for schizophrenia and co-occurring disorders in the state of Missouri, and we're picking one other state here in the next 30 days. And the whole idea is to do exactly what was pointed out, to bridge disease states, to really look at the issue of, yes, the person you must have a diagnosis of schizophrenia to be reviewed, but the whole focus is on co-occurring physical health conditions. Again, using existing data sets, supporting the existing treatment system, educational in nature, and based upon continuously updated best practice guidelines from both mental health and physical health. Interesting issue nationally, and this is in 2003, the Kaiser Foundation reported that if you look at the Medicaid enrollment in the U.S., there were 48 million people enrolled in Medicaid, of which 7 million in 2003 were there because they were blind and disabled. By November of 2004, CMS released a new bulletin saying that number was up to 9 million. And with the states we're working with, they're seeing about maybe a 2% growth in their overall Medicaid enrollment, but a 15 to 20% growth in the last 18 months in the number of disabled people in the Medicaid program. When you look at again, this is Kaiser data. Kaiser in 2003 said about 10% of all the blind and disabled were a person with a diagnosis of schizophrenia, but they were 25% of all the Medicaid spending for blind and disabled people. Also, a lot of complicated issues here with the new Medicare bill and what the impact will be on blind and disabled people with mental illness if their medication benefit is pulled from the Medicaid program. Okay, Missouri. We actually started by the Missouri Medicaid people turned over their entire data set to us over a year ago to really start looking at this issue. And what we know is out of 523,000 enrolled members, there were 19,700 in the year 2000 that had a diagnosis of schizophrenia. Out of that number, just under 10,000, 9,700, were on antipsychotic medication at a dosing level and a duration associated with maintenance therapy. So once we got that number, we then went in and did chart reviews and reviewed clinical records. And ultimately what we found was that out of that, if you will, 19,700, there were 2,000 people that were using a great deal of services, physical health, pharmacy, and mental health, to the tune of actually it was 55,000 per recipient per year. Keep in mind that no institutional services, no state psychiatric hospital days, no indigent care money from the Office of Mental Health. This is only Medicaid paid claims, either for outpatient services or acute inpatient or emergency room services. So what we were able to say to the Medicaid people is, you've got 2,000 people that you're spending $100 million a year on. I mean, this is not an issue here of lack of money, it's where the money's being spent. And that what we were able to say to them is that small percentage, that small number of people, 2,000 people out of over 500,000, accounted for 2.5% of the entire Medicaid budget for the state of Missouri. Not surprisingly, big issues around medication adherence problem and very complex medication plans. It is not uncommon to see in any given month these patients seeing many physicians, having, as Ken showed you earlier, maybe it wasn't as bad as the chart he showed you, but don't be surprised to find people on more than 15 medications a month, and that includes the physical medications as well as the psychiatric medication. When we did the chart reviews, and we have 6,000 records that we've been reviewing, that the chronic health disorders are high-risk conditions such as obesity, rapid weight gain, diabetes, chronic heart conditions, hypertension, HIV, hepatitis C. Not surprisingly, no stable medical home. These patients, the record is one person seeing 300 doctors in a calendar year. And frequently, people that were well known to the community mental health center, but who have refused to offer the services that are providing. And then also, the co-occurring alcohol and substance abuse problems was interesting. The diagnosis would be in the record, but you'd find no treatment. So the recognition that person had the co-occurring disorder, but you couldn't find anything, any place where there was active treatment. Now, what are we doing? Well, again, this is a suggestion to BU, is to really look at what's going on in risk prediction. It's a whole new literature and a whole approach to really thinking differently about how to organize both data and organize clinical intervention. What we've done, it's taken us about 2 years, is we've actually developed an algorithm whereby we can run a state Medicaid data set, and we believe with 70% accuracy predict who's going to be the high-cost person next year. That's the holy grail. I mean, David and I messed it up in New York because we didn't think that way. We didn't recognize that you could use the clinical and medical conditions that would be highly predictive of future use. A lot of us are old hands at mental health, and we were absolutely stunned when we finished the model. We actually looked at over 70 variables. We had 30 months of data, and the number one predictor of future use of a great number of Medicaid services started with, and you had to have all of these to make the criteria: obesity, not diabetes, but obesity in the record, a female under 35 years of age with a co-occurring diagnosis of depression. The likelihood that an obese female with depression was going to be a very high user of medical and mental health services for the 12 month and 18 hours was extraordinary. And we simply didn't see it coming. For the patients that get enrolled, this is an administrative program. It's administrative case management. It's relatively inexpensive. We're talking about $1 a day. That the psychiatric physician, the clinical case manager, and the primary care doctor, if there is one, each month, well, actually, we're going to do it each quarter, will get a comprehensive profile of their person, their primary diagnosis, all the medications they're on. They'll get told who the different physicians are. And embedded in that is what's called care consideration. We work with a company called Active Health. And Active Health has spent like 8 years perfecting a tool that warns physicians of coming risk. And so embedded in that, we'll let them know that the person has a diagnosis of diabetes and is on a medication regimen that makes no sense for the treatment of diabetes. We also, I'll get to this next one, the medical briefs and alert tracking. We've had to actually write a whole new, if you will, set of medical education briefings for case managers. What we realized was that in many of the states, the case managers are the ones that could probably be our best partners in change. But case managers are not familiar with working with physical illnesses, so we've actually created, the VA's done a lot of work in this, so we have a group of community psychiatrists and VA psychiatrists that actually have, when we're just about finished, a series of educational monographs that will focus specifically on severe mental illness and physical condition, and actually recommend to the case managers what they should be asking of the primary care physicians and the psychiatrists. One of the things that I'm leaving out is we've also are putting a full-time nurse practitioners embedded in the state Medicaid agency or mental health agency to really work on the issue of medical home. So what are we expecting? You know, the goal of this, and there actually will be, it looks like the Florida Mental Health Institute will be evaluating this. We're hoping to see medication adherence improve, the reduction in emergency room and inpatient events, medical misadventures decrease, high-cost services decline, and overall health improvement. So what's the overall message? There are a lot of data. There are a lot of problems with the data. There are a lot of false positives. There are incomplete cells. But if you organize data in a way that is longitudinal and historic, you can actually come to some interesting decisions about who needs attention. Those data sources need a lot of work. They need to be reconstructed, if you will, but there are new techniques that are emerging every day that make that possible. And I think very important from my point of view, because I've always believed this, caregivers want to do right by their patients. Especially, I think, in the mental health system, that people really want to do the right thing. We have not helped them do the right thing in many cases. We have a very fractured system, and so the whole effort of where we're coming from is how can we be data miners and organize data differently so those that have the responsibility both have the knowledge of best practice and also have new information, that actually old information but organized differently, that increases the likelihood that they're going to be concerned about the physical health status as they are the psychiatric status. Thanks a lot.
Well, Richard, I've been fortunate in my career to work with lots of really great people, many of whom are here today, and Richard is certainly one of them. And he is sort of a master of the art of the possible and finding levers to make things happen, and that, I think, is part of our challenge. Now, and I'd like to say a few more things about that, but Catherine Power, unfortunately, has got to run to catch a plane to go off to speak with another group or to work on another project. And so what I wanted to do is, prior to Catherine's leaving, to open the floor to questions or observations with regard to her remarks, and then we'll come back and try to do some general synthesis. So sort of switching gears rapidly, are there remarks or questions for Catherine Power? Back over here. Is Cheryl? Okay, go ahead.
Yes, thank you for a very inspirational presentation. My concern is in the President's New Freedom Commission that emphasizes time and again the consumer and family-driven service system. You might want to change your slide to reflect that, the one that says being a partner, teacher, coach for, quote, consumers. You may want to think about, recommend, being a teacher, rather than teacher, a student and a partner of people receiving services also.
Okay.
And the other thing I wanted to note was the interesting quote that you opened up with from, I believe it was Newsweek, that talked about the physiologic correlates of emotions that arise within the mind.
Right.
Well, my knowledge of neuroscience is very limited, but from what little I know, that these physiologic states do in fact arise from the body and go to the mind in somatic afferents, where there's a switching station below the level of conscious awareness, and that in turn redirects blood and physiologic indicators, and that's how we have the polygraph. So it's really more than just a conversation. It is in fact both. It's happening both and that's the lay press. And I would just, you might want to make some clarifying comment.
Thank you very much.
Thank
I
you.
appreciate it. I think one of the reasons we picked up on the Newsweek article was because it was sort of timely, and it really reiterated what I thought was one of the most important statements in the 1999 Surgeon General's report, and that is that the mind and the brain are the seat of cognition, emotion, and memory. And so if the brain is considered the seat of cognition, emotion, and memory, it is really one of the galvanizing organs in the body. And so we were picking up that thread from the Newsweek article, which we actually thought had some terrific value and timeliness. But thank you for your comment. I appreciate it.
Thank you for the great talk and for invoking Seneca from millennia ago. There's a political issue and a change leverage issue that SAMHSA may be able to help with. At least within the medical profession, since the 19th century, there have been elegant models from the leading teachers, Sir William Osler, 25, 30 years ago, George Engel. The concepts for mind-body integration are there. They have been recurrently reinvented. There's a bandwagon, great enthusiasm, then it goes away, then it's reinvented. I've thought about this a lot, and what it's led me to think is that we need not just new concepts, but new levers. Richard presented one in terms of the data manipulation, data mining. But I think a key lever here could be consumer and family demand for these services. And insofar as SAMHSA can aid and abet that, that might contribute. It's not the absence of models that holds us back here. Every medical student is taught the biopsychosocial model, and it doesn't make any difference. And these same issues of integration would be heard at conferences on other chronic and recurring illnesses. So at a diabetes conference or an arthritis conference or a GI conference, it's not just in our field that this Cartesian disintegration happens.
Well, I think that we are looking very, very closely at the ways in which we can help facilitate that at CMHS and at SAMHSA. We agree that we believe that the rise of the consumer demand issue, I mean, if we chose the word consumer for a particular reason in this movement, why is it that consumerism did not come along with it? It's one of the ironies of the system. And so where is the rising demand? And whatever we can do to work with not only consumer organizations and family organizations, but other sectors that really should be raising the demand for appropriate services. I care as much about this whether I have a mental illness or there's a person in my family with a mental illness or there isn't. It shouldn't matter. Right. There should be such a rise of consumerism about about the integration, and we're hoping to use some of the opportunities in 05 and in 06 to be able to help facilitate that discussion. So thank you for that.
Any other comments or questions, observations for Catherine? Oh, hi, Courtney.
I'm Heidi. Catherine, thank you so much for coming and for not only your presentation, but for your passion and the caring that you show. I want to raise a very provocative question that I didn't dare raise in the last meeting we were in. It seems to me that the end product of what you're talking about is an integration of SAMHSA back into NIH, and that we shouldn't have departments of mental health, we should have departments of health, and we shouldn't be separating out this kind of disorders that we all care about so much that they should be integrated into health departments and health institutes?
I think I said that. But I think it could be implied in terms of some of the conversation about the fact that we expect that, and SAMHSA is very clearly expecting that people will begin to take a look at this as a public health issue. The reality is we believe that it is important to stay focused on mental health as a part of the public health issue. So the notion that you're not necessarily blurring the lines, but you're paying attention to mental health in the construct of public health, I think is very important. I do not believe, personally, that mental health should necessarily be on a state level in the departments of public health, because I think that sometimes their focus is very different. But taking a public health approach in mental health does not mean that I'm encouraging that necessarily on a state level that they should be reintegrated. SAMHSA is definitely not interested in reemerging with NIH, I can tell you that. It's very clear what Congress decided, and what Congress decided was that NIH, and in particular NIMH, and it might be interesting, David, to think about that aspect of this, about where they are in this whole construct, about this discussion. They do research. That's their job. We do services. That's our job. And that's very clear. And so we're going to continue that. We're in partnership with them around a variety of issues relative to research. But I would, in fact, be encouraging more research in the connection between recovery and physical health on the part of NIMH. But I clearly do not see that. We're not being reattached to another agency. We're going to stand as SAMHSA for some period of time to come. But I think that it's important. I really stress the issue that it is important for mental health practitioners to understand public health, because data is important, and because we ought to be driving a lot of health decisions by data, and that means having a public health perspective. But I in no way, shape, or form would ever say that the Center for Mental Health Services should become something other than the Center for Mental Health Services, because I think it's important to stay focused on mental health, particularly as we're looking at transformation, and particularly if we really do believe in the integration of the mind and the body, we've got to focus on mental health. So that hopefully will be what we do. Okay? I think with that, if there's another provocative question for me, I think.
I would just suggest that we look at obesity as a form of eating disorder, and we don't do that very well. And many times we've not factored in process addiction, in gambling, in the addiction scope. And most of us who know and love many of the other people in our programs are just being eaten alive by lottery tickets and scratch tickets, are filling wastebaskets outside of day programs and hospitals and everywhere else. So I really think that, again, the addictions community, I think, has a lot of solutions for us with this obesity, and looking at food addiction as a possible cause of these drifts to obesity. So.
First time, certainly the Center for Mental Health Services is working more closely with its partner centers at substance abuse treatment and substance abuse prevention. And I also believe that when we talk about mental health, and I know certainly when my boss is out, Charlie Curie, talking about broad issues, we talk about behavioral health. We just don't talk about mental health. We talk about the fact that many, many individuals have both behavioral disorders, addictive disorders, and mental illness. And so the notion that you can be thinking more broadly about behavioral health, I think, is an important one. And frankly, the realities are that one is usually not separate from the other. And whatever you're doing in terms of your behavior, whether it includes the way in which you eat, the way in which you work, the way in which you play, all of those things are very, very important, and I think move us more towards looking at people holistically, which means not necessarily just separating out their physical health and their mental health. So I think that's very important. I'm sorry that I cannot be with you for the rest of the day today. This is the most important work, I think, that's going on in mental health, and Bill, I congratulate you and the rest of the center, and I hope to see you all along the way someplace else. Thank you very much.
Catherine, thank you. So I think there are several interesting observations. One is the importance of behavior to all health in a way, and thinking about things like cardiovascular health, problems with obesity, problems with other kinds of addictions and addictive disorders. I think that's an interesting organizing frame to start to bring together this, what I strongly now believe is this false dichotomy between mind and body. I'm intrigued by the comment about looking for levers. I mean, I think that's what Richard's talk was about, in a sense, is trying to find levers that, number one, part of the issue with consumerism is the consumer is the health insuring entity typically, not the person who's receiving care. So you notice who Richard is appealing to is the purchaser, and he's trying to bring a product to them because we purchase health services on behalf of people, and that makes the problem a bit more complicated. However, I think that this notion of trying to have sort of multiple vectors pointing in the same direction is really important. The other thing Richard talked about was cost containment. We have to continually remind ourselves that we have the most expensive healthcare system in the world, bar none, and our outcomes aren't even in the top 20 industrialized nations in the world. So we have lots of money, in a way, but it's the way we spend it and target it. And that's why I'm very intrigued by trying to develop technologies that support people to do the right thing. And it's intriguing, Richard, that physicians are very interested in learning what some other physician is doing to their patient, but are less, in some sense, perhaps less sensitive to some particular feedback about themselves, although your data is actually quite encouraging. So great comments. Courtney wants to reorganize the government, which is always a great place to start. And why don't we open it up now for observations or questions for Ken and Richard. Dory, did you want people to come up here? I don't know how the videotaping works. Okay, so we'll just continue to use the same notion, and you two fellows will just stay right where you're at, Ken and Richard. So general comments about any of the presentations or any kind of the themes that have emerged to this point.
Yeah.
Would you introduce yourself, by the way?
Yeah, I'm Steve Holichuk. I'm the Director of Consumer Affairs for the Massachusetts Department of Mental Health. When Ken showed the slide on the use of antipsychotics at various facilities in Massachusetts, I was really troubled that the Fuller Mental Health Center was significantly at the top, because the Fuller is a mental health center that serves primarily poor urban consumers of color. And I think the point I want to make off of that observation is I think, at least in my hearing things, there's been a mind-body is wonderful, but it's the mind-body-society connection is really the most holistic and systemic approach to take. And it would really be helpful, I hope it's going to happen sometime today, that, I mean, social inequalities based on class, race, and gender, and certainly what we could learn both in theory and practice by comparing people labeled with a psychiatric disability to other oppressed communities, African Americans, also women, whatever, that those kind of cross comparisons and what works and what doesn't and what are causal factors would really be a broader approach than the important start I've heard today.
Ken, do you want to react? Yeah.
I agree, Steve, and that was exactly why I showed that slide, because that was something that kind of knocked my socks off. And when I met with them, that was one of the things that they observed, is they wondered if that was true as well, that people came to them on multiple compounds in part because they were different than the providers. People don't get to the state system before they go through the acute system, and usually they run through it multiple times and in many fragmented places. So they arrived with that as one of their kind of card-carrying elements. And so, like Richard, I share the belief that whatever the data is, you just put it out there, and then you try to work with it. So that was something we did with the Fuller. And I just want to comment on Mo's comment about obesity, now that I have the microphone. The culture change that has happened, and I'm just adding to this, this is particularly true for African Americans who have a higher incidence of diabetes. The medicines that we give people now cause weight gain. That's a new thing. I wasn't trained to talk to people about managing their weight and thinking about how they eat. The model I was trained in, a very famous place, was I do symptoms, you run your life. Now my symptoms interfere with your life. It's a completely different way of thinking about our work. Everything I do, whether it's sexual dysfunction from an SSRI, weight gain from an atypical antipsychotic, the risk of a seizure from clozapine, almost every intervention that I do has a side effect. And what's important about that is they're all lifestyle things. So to me, it just makes for a richer clinical conversation. So we can talk about, let's watch your weight, let's talk about your exercise plan, because this medicine is still likely to help you. But if you don't take care of your body, and I frame clozapine as psychiatric chemotherapy, you're going to take psychiatric chemotherapy, and it's going to be really, really hard on your body. So if you don't take care of your body while we're getting your brain back, you know, it's not going to have been worth it for you. So I feel like this whole conversation is moving in many dimensions. But the disenfranchised minority population has greater health risks on top of. So both your question and Mo's question are directly connected.
I agree. I think it's very, your point is a really important one. I think when Catherine talked about trauma and the importance of trauma and the prevalence of trauma, it's interesting that when Richard talked about females suffering from obesity, my guess is a very high rate of trauma in that group. And if you think about trauma as a sort of a social condition, it talks about the interface of people in the communities and society in which they live. And what we can't get, from my perspective, what we can't get lost in, again, is some sort of an argument about etiology, trying to find out like what the real true cause is, whether it's all environmental or all genetic. Somehow it seems to me those arguments are just buried in this false dualism between mind and body. That being said, it's really important to remember that we do live in communities, and some of the stuff that Dory and others are talking about is a much more holistic notion of people acting in society, and equity and equitable access to resources, personally for me, is a very important part of that conversation. So thank you for that comment. It was excellent. Other comments or questions for go ahead. And please introduce yourself for everyone's benefit.
John Pelletier from Assumption College and UMass Med School. Just some practical concerns. I recently co-PI'd a study of a supervised exercise program for members of a psychiatric clubhouse, and have a new proposal out ready to go that combines nutrition with exercise. Not rocket science. We all know this stuff is helpful. And of concern is, as we think about all these needs, is how do we pay for them? How do we integrate them into our service structures? Who's going to pay for that? Both in terms of staffing of programs, but also getting insurance, Medicaid to pay for interventions that are designed to affect the kinds of changes we're concerned about. So a very practical set of questions, and I hope that as we think today about these concerns, that we leave here with some emerging thinking about how we start to pay for these interventions and really deliver them in very high quality ways within our mental health and other allied programs. Thank you.
Richard, would you like to comment on that? Because I think disease management approaches try to get people to pay for healthful behaviors for people who are already pretty ill to avoid more significant causes. To get to a real public health notion, we need to move that back into a more preventative framework, and that's tough to do with our current purchasing system. But why don't you talk about that a bit?
Well, I think that is the challenge. I think in the last 18 months I've actually been in 40 states and met with Medicaid and mental health, and people are, there is not much of an appetite for new entitlements, new programs, new initiatives that create vast new government programs. About the only thing you can get people to pay attention to is the things we're doing now aren't working and they're costing you lots of money. So there are a couple of things we can do. We can try to get a lot better at saying, and this, I don't like the concept. I mean, maybe I'd like, I'm actually a Southerner. I call myself a strict constructionist liberal Democrat, a dying minority. We know our Medicaid benefits very problematic. There are 50 states. There are 50 different benefits. There's extremely conservative reaction in many parts of the country that's very antagonistic towards people that are on Medicaid, not to mention people that are ill and disabled. So I think the strategies have to take into account we're not going to get lots of fresh money to do some wonderful things in improving health care unless they get themselves attached to the kind of environment we're in to say, yes, we can do risk prediction, yes, we're spending money in exactly the wrong places, and if we can rearrange care, then we can make a change. But I think we're going to have to accept the fact that it's going to have to probably be within some type of disease management framework. That is, that you're going to have to identify people that have that the data suggests are at critical risk, and if we don't dramatically change the way their services are being delivered, then we'll all fail. I think that's kind of an incremental strategy to really say that, yes, we can do this better and different, but we need to be focused now, one, on the integration of medical and mental health, and two, the strategies need to be different.
I would add to that, scales are $8 at Target. And when I said to the psychiatric nurses at the Clozapine Clinic at Mass Mental Health Center, I'd like us to start weighing people because I'm going to all these memorial services and I think there's a connection. What they said is, we don't want to weigh people because then they'll know how much weight they're gaining. True statement. Wow. So, wow is all I can say. So we have some cultural work to do. The other thing I do is just want to put in a plug for assertive community treatment. Assertive community treatment is a very expensive thing to do. It's $800,000 to take care of 60 people. It saves money, it improves medical care, and it's a great idea. It has this very curious feature. It was not invented in Massachusetts. It's a shocker for us all. And so when I was in one of my old day jobs, we started 14 teams around the state. And I'd encourage you to look into the teams near you. These people are getting great care, and they're getting back to work. And I think I've come to the conclusion it's the only kind of clinical work I'm going to do because it's not all about fragmentation. It's all about integration. So that, I think, is a good example of something that looks really, really expensive but gets better health outcomes, better hospitalization outcomes, and better recovery outcomes. So I think there's a lot of ways to spend money in different places, but scales are pretty cheap.
What's interesting about assertive community treatment is it wasn't invented in Massachusetts. Actually, as everybody knows, it was sort of first studied in Madison, Wisconsin, but that was also a significant detriment to rolling it out because every place didn't know exactly who they were, but they knew they weren't like Madison, Wisconsin. And so just like psychiatric rehabilitation, for years people said, well, that might work in Madison, Wisconsin, but it'll never work in New York City. Richard, yeah?
The biggest problem with ACT was they didn't figure out how to pay for it.
Right.
That it was, they were totally unconcerned with the issue of how do you pay for ACT teams?
Right.
How do you change the state regulation? How do you integrate into Medicaid? And so it went 15 years before we could actually get people's attention to figure out how to pay for the service. It's
an excellent point. And I'd just like to make a point that I think Catherine would have made if she was able to stay with us, and that is that thinking the global burden of disease work that the World Bank initially financed and now that the World Health Organization is working on is trying to monetize health as a resource in communities so that we can start to think about investments in health having a return on investment. I'm encouraged that a group like the World Bank, which has an international leadership role, is trying to reframe the issue in that way, because it might get us to start thinking a little bit more from a public health perspective and less from a particular budgetary perspective. Richard works with a Medicaid authority that has a specific problem to control costs in their budget. And in some sense, they don't care if they shift costs onto families or onto corrections or onto any other payer. They just have an objective. Somehow we need to frame these issues more broadly in terms of the overall costs. And I think that the World Bank studies and the initiatives that Catherine talked about in terms of labor and economics becoming very interested in this might be an important lever to sort of get this thing monetized in a way that seems to motivate our action. Yes?
I'm Ann McDermott, and I'm from the Human Nutrition Research Center on Aging at Tufts. To follow up on the exercise nutrition intervention, one of the things I think we need is more cost-effectiveness analyses run in conjunction with interventions. Yeah. Because to say it does something to glycosylated hemoglobin and diabetes risk is great, or to say we can do it in a community, but only when we get to the bottom dollar is what does it cost us, and what does it cost us if we don't do that thing? And that's what's going to, I think, going to get the system to kind of look in a different direction for what the payment really is.
Particularly if you can link that to someone's expense or some entity's expense. That's the tricky part. I wish I knew more about how sort of public health models that informed us to start vaccinating people or treating people with tuberculosis. Well, I guess I do know. I mean, those are contagious diseases and thought of that way. But we probably need to know a little bit more about that history and how those issues were moved forward, because it is a matter of the public's health. And when you have this distributed benefit and a distributed cost, it becomes harder to sort of move, to find those levers that we were talking about earlier. Go ahead, I'm sorry. Anybody else?
Yeah. Sorry.
There we go.
My name is Linda Chaffetz. I'm from the University of California School of Nursing.
There you go, Linda.
I just wanted to say that in terms of looking for models for things like hemoglobin A1C, for example, and what would happen. This is where this separation is so difficult. Again, the Bureau of Primary Health Care is funding health disparities collaboratives all over the country that are using these kinds of markers, and they're using them for diabetes and cardiovascular disease and depression. And this kind of technology shouldn't be that difficult to adapt. And there already is a comparison group of hundreds of thousands of clients that they've treated. So I think sometimes we have to see what the other people are doing with these kinds of things.
Now, could you say just a little bit more about that? You said that the Bureau of Primary Health within HRSA?
Well, I'm not a big expert on this model, but there's something called the chronic care model, lately called the CARE model, that I guess was developed at some institute and then refined by Robert Wood Johnson, and it's a health promotion model, and most of them are pretty overlapping, and they have the same kind of concepts, but this one, for people who are implementing it, provides people with technology from the systems level down to the patient level to implement it, including software to set up client information systems that can produce reports on individuals and on groups. So, and there are probably a million things like that. That's just the one I happen to have heard about. But I think sometimes we try to reinvent the wheel when there are things that we could latch onto.
And traditional mental health concerns like depression are part of that package. That's
yes, but
yeah.
But actually, I don't know how well they're going to do with that, because some people who have depression have milder depressions, and some people have very complex depressions, and maybe we need collaboratives that look at very complex populations with psychiatric disorders.
Right. Part of what Richard was talking about. Now, I'm mindful of the fact, Dory, that we're at 12:15, and then we wanted to break for lunch at noon. Give me some process guidance here.
Why don't we stop?
Huh?
Why don't we stop?
Okay.
I will orient people to lunch.
Okay, let me just say just a couple things about the themes that have emerged. I mean, we talked about sort of our inertial, our professional inertia. We talked about our historical inertia in terms of thinking about mind and body separately, and how we've continued to reinvent that problem. I think we talked about being at a very propitious time in terms of lead stories in Newsweek and the global burden of disease, and the fact that these mental health, behavioral health problems are now, I think, much more center stage in terms of big health than they have been traditionally. And what we're kind of struggling with now is, number one, not reinventing the wheel, making sure that we understand what our colleagues in other areas of health are doing, a very important point, but also sort of picking up on Richard's point, looking for those points of leverage to start framing the conversation in a way that will have traction for policymakers, perhaps starting with disease management models, although that comes out of a somewhat different tradition. It is preventatively focused for people who have more severe disorders, and looking for ways that we can start to cast these issues so that they have currency for communities. At that point, I don't know exactly where to go, but somehow it seems to me like that's an area in which we need to be working. We should be able to do it, however, because if we know anything, we know that these issues touch almost everyone's life, either personally or in terms of a member of their family. So with that said, Dory will now tell us about food, which is good. This is our nutritional midday fix here.
Nutritional intervention. Thank you, everyone, for your participation this morning. And before we break for lunch, I want to make a point of thanking the Laura and Lorenz Reibling family for their support of today and value options. We couldn't have done this without them, and we're very appreciative of your support.